Good morning, everyone. I'm Steve Braunstein, a radiation oncologist here at UCSF, and I have the pleasure to present today talking about some of the latest approaches for brain metastases. In the next 20 minutes, I'll talk about, at a very high level, the biology of brain metastases for melanoma. I'll talk about treatment outcomes of patients with brain metastases, and we'll talk about modern interdisciplinary and multimodal therapy for brain metastases. So first, for the biology. The biology of the metastatic state in general is very interesting. At a very high level, we understand that tumors of different origins, say lung tumors versus kidney tumors, prostate tumors, and of course, cutaneous tumors as melanoma, they have a different propensity to go to different locations in the body. And so a prostate cancer, for example, that likes to go to bone is different than, say, a melanoma that has this great propensity to go to lymph nodes, liver, lungs, and of course, brain. And as we'll see, part of that has to do with some of the intrinsic properties of the tumor, but also properties that are coming, what we say, extrinsically or epigenetically. But for a tumor to migrate from a primary site to a distant site, essentially all tumors go through this progression. And when they become metastatic, not all tumors become metastatic, but the key steps include evolving in such a way, usually genetically driven through mutations, to locally invade whatever space they reside in this case, cutaneous areas, invade and then enter blood vessels through intravasation. Once they enter the blood vessels, then they can enter the circulatory system, in some cases through lymph channels as well, and then arrive at their distant site, say within the brain, the blood vessels in the brain, and then extravasate, move through those blood vessels into the local area, and then ultimately take up residence and colonize. And if that seems very complicated, in fact, it is very complicated biologically, which is why it doesn't happen with such great frequency for many tumor types. And so we talk about this concept that the process of metastases has to do with both the properties of the tumor cells themselves, but also the larger environment. This concept of the seed being the tumor cells in the soil, the larger environment. So I mentioned that there's gene mutations that can occur within a tumor shown in the center there. And then those mutations can incur the ability to locally invade and leave that area. But it's not limited to just what's happening within the tumor cell. There's other factors as well. There's environmental factors, epigenetic factors. It has to do with your age, stress hormones, other hormones, and also signals that are coming from your immune system, signals that are coming from your microbiome. So when we're talking before about diet and exercise, all of that can potentially influence this metastatic state, although we don't quite understand it well. And so ultimately, it's not just about the tumor cells, it's also about the location where they are headed, in this case, the head, the brain. So if we look at different tumor types, I'll bring your attention to melanoma here. The actual incidence of brain metastases in melanoma for all presentations is relatively modest, about 10%. But if you look at patients with metastatic disease, patients who have disease that has moved on to lymph nodes and beyond, it's about 50%. And that's why I'm talking today, because it is a significant finding and an issue within patients with melanoma. And why is it? What is it about melanoma? Well, again, at a very high level, what we understand in terms of the biology is that these metastatic melanocytes, they actually possess the capability to secrete these proteinases, these molecules are able to digest their local environment, their local attachments to promote their migration. Once they migrate to the brain, they're able to enact programs to provide what we call neoangiogenesis, to actually cultivate blood vessel development within the brain. And that's actually helped through signaling from the local brain tissue, the astrocytes, and that promotes their growth because they need nutrition, a mechanism to be able to sustain themselves once they find a new environment. And then some of the signaling pathways that have already been discussed, AKT, PI3K, and BRAF signaling, can actually selectively promote growth within the central nervous system. And this is all intrinsic to melanoma. So going from that high level view, we'll talk about in practicum, how do we address this in the clinic? And again, as a radiation oncologist, I work closely with my colleagues in surgery and medical oncology for optimal interdisciplinary management. So what does the presentation look like? Well, the presentation can be actually highly varied. And so you can have folks, these are images, MRI images of brains, what we call the axial section, sort of looking from the bottom up or top down. So you see the two hemispheres of the brain in three different patients or three different presentations. So some patients may present with a single lesion. You can see that on the left. That's sitting there in the brain. It's just a single round lesion, which represents actually several thousands or millions of metastatic cells, but in a single location. In the middle, you can see patients who might have multiple lesions, so multiple metastases, one that you can see on the bottom, one that you can see towards the center, and others that are very small, but present. And then all the way on the right is what we would call the more fulminant or leptomeningeal presentation. And you don't see necessarily discrete round nodules there, but what's actually represented is the covering of the various surfaces of the brain, in this case, the cerebellum in the middle, with tumor cells. It's sort of caking of tumor cells. And that can be very serious in terms of the symptoms and the prognosis. Well, historically, decades ago, how did we approach this? Well, we approached this very elementary means by using brain-directed radiotherapy and something we would call whole brain radiotherapy, which, again, very simply is to treat the entire contents of the brain with high-energy photons. And this just shows essentially the aperture of the machine that delivers that radiation. You'd have a beam coming from the left side, a beam coming from the right side. You'd block out the structures of the face, and you'd be able to treat the entire contents of the brain. It's effective at treating tumor cells, but as you saw from before, in some patients who present maybe with a single lesion, it seems to be a little bit of an over-treatment. And the problem, of course, is it comes with a fair amount of toxicity. Having a brain-directed radiation therapy, especially very large volumes of brain tissue, can cause changes, scarring that can lead to cognitive impairment, decreased quality of life. Also, if it's given concurrently with systemic therapies, because it's not just about the brain that we need to focus on, it's the entire body, that it is very challenging. And so in the subsequent decades, we've been able to refine our approach, especially from a radiation perspective, with development of better technologies, and be able to do things such as stereotactic radiosurgery, which is just focally treat the metastases as we're able to visualize them on MRI imaging. And it's a very effective means to be able to treat these individual lesions. And it can be done multiple times over the course of a patient's care. And the nice thing is that it spares treatment of uninvolved brain tissue, so spares toxicity. But again, one size doesn't fit all. And so for managing patients with brain metastases, we are, again, using combinations of surgery, focal radiation, systemic therapy. I'll talk about that a little bit more in a moment, as well as in some cases, comprehensive radiation, which is appropriate. So why is it such a problem, brain metastases in these patients with metastatic melanoma? Well, the melanoma cells are very able to migrate into the brain, use that capacity to invade through the blood vessels to get into the brain substance. But actually, chemotherapy, at least traditional chemotherapies, are relatively impermeant or impenetrant to brain tissue, because we were designed, in a sense, with this blood-brain barrier, this dense connective tissue network that's made by combinations of the vasculature and the coverings of the vasculature in the brain. So we walk around with this blood-brain barrier, which is a very tight mesh network that actually keeps out toxins, microbes, and other pesky things that we encounter as we walk and forage and spelunk through this planet. And that's great in life because it keeps us healthy and keeps us from getting critical infections and subject to toxicity. However, it also can keep out meaningful therapeutics from the brain. And whereas tumor cells are able to avert this most of the traditional chemotherapies were not able to effectively collect and enter into brain tissue in a meaningful degree to fight those tumor cells. So sometimes we talk about the brain and spine, which is also covered from this as a sanctuary site for metastases. So whereas these chemotherapies work for metastases that occur in the lung or the liver, they don't work as well in the brain. So just to pivot a little bit, I didn't say much about surgery, but surgery does have a role in the treatment of brain metastases, especially for those that are larger, causing symptoms. Having a surgery done can immediately remove the tumor and decompress and help with symptoms. There are some risks, of course, associated with surgery, even in the hands of the best surgeons, and especially in areas that we consider eloquent or very sensitive. So areas that, for example, control motor function, and overaggressive surgery can leave a patient with a deficit. The other issue is that the instrumentation from surgery can create the potential for some local residual tumor cells being present and recur in the absence of additional therapy. So even for patients who undergo surgery, at least historically, for the vast majority of them, we will do some additional or adjuvant radiation after the surgery to help address any potential microscopic seeding that can happen with surgery. The nice thing about that is it can be done very focally, as you can see here. So we really just have to treat the immediate surgical area. And that can improve what we call the freedom from local recurrence, or improve the control in that area so that tumor doesn't come back. But as you can see from the curves, it's not perfect. Again, the challenge from surgery, I show what I think is a very beautiful diagram of advanced MR-based imaging showing these highly connective pathways, these tracks that occur between different functional regions of the brain. Some of them are more sensitive or eloquent than others, and any type of surgical disruption of that can lead to significant deficits. So in fact, the surgeons in this day and age do what we would call mapping and sometimes awake-based craniotomies, where they're actually functionally being very much aware of these tracks to avoid them when they're doing their surgeries currently. With radiation, we can access any part of the brain, and we can do it relatively safely. And I show by way of extreme treatment of a brainstem metastasis, you can see here. So brainstem being a very critical and eloquent part of the brain, we can functionally, focally treat this with stereotactic radiosurgery and almost immediately, in many cases, see reduction of the lesion and over time dissipation. So that's an advantage of radiation. Now, radiation and this focal radiation is an answer to every situation. There are some patients who present with more widespread burden of intracranial disease where we just don't have the technical ability necessarily to treat all of those lesions. And so sometimes we do need to reach for that more comprehensive whole brain radiation plan. But we do have, with some recent advances in our studies of different functional territories of the brain, we can identify some areas of the brain that perhaps more eloquent importance, and then effectively avoid treating them, provided they don't have evidence of disease in that area, using modern radiation techniques. So, for example, avoiding the hippocampus, which is a basal structure in the brain responsible, as we understand it, for a fair amount of short-term memory. And so there's techniques that we can use to avoid some of these eloquent areas. Other studies have been done where not only do we do that type of technique, but there's medications, neuroprotective agents, such as memantine, historically used to treat Alzheimer's disease, that we can do in combination and actually reduce significantly the toxicity of this treatment while maintaining the efficacy of treating patients who have a high burden of disease in the brain. So that's an example, I would say, of de-intensification. But what about on that extreme end, those patients with leptomeningeal disease? Again, you see here a patient without discrete nodules, but you can maybe appreciate that with in these images, you can see these white streaks, again, of these little tumor cells that are filling all of the spaces, the sulci of the brain, and they're also present in the spine. It's a pretty fulminant presentation of disease. The brain and spine are connected. There's recent studies that have been done using more comprehensive radiation, actually treating the entire brain and the entire spine, that have actually showed some benefit in a variety of patients that have this type of fulminant leptomeningeal disease presentations. Now, this is data that was done specifically for patients with breast and lung, but now this is primaries, but now this is being performed in a larger trial for patients that include metastatic melanoma. And there's techniques of radiation, something called, for example, proton-based radiation, which is a little bit more, I would say, focused or conformal, so that you can really limit the treatment just to the brain, the spine, and not scatter dose to other parts of the body. So we are able, in some cases, to consider to do these more aggressive types of intensification. Now, it's interesting. Overall, if we look at data for patients with metastatic melanoma, we've seen actually improvements in overall survival in the modern era from the time period of 85 to about 2005, now from 2006 to 2015. You can see the survival curves have improved over time for these patients with the significant burden of disease. Now, that is in some way part to improvements in radiation and surgical techniques. But when we look at the modern interdisciplinary management, we really have to focus on what you've heard this morning from Dr. Tsai and Dr. Moyers, at least in terms of the new precision-based therapies, the targeted therapies, the immunotherapies, recognizing that we can more precisely deliver these agents to target specific mutation in a specific patient's burden of disease. And that's borne out to lead to better overall survival, specifically in patients with brain metastases. And the really amazing thing is that many of these agents actually cross the blood-brain barrier as compared to traditional chemotherapies. And so in various studies, you can see intracranial response rates that are over 50%. And so that's really exciting and encouraging for our community. And, we are at a place now, and this is showing a variety of targeted agents. This is a nice review, that there are some agents, as you can see on your right, including dabrafenib, trametinib, and the ALK inhibitors that actually have shown to have a pretty decent CNS response, central nervous system response. And so, and this becomes better and better seemingly with subsequent generations of these inhibitor therapies. And so, when we look at, for example, immunotherapy as by way of example for patients with melanoma brain metastases, a CheckMate 204 trial, which included patients also with asymptomatic brain metastases getting ipilimumab and nivolumab, the response rate was over 50%, which is really amazing. And the CNS-specific toxicity was very limiting. So if you look at the response curve, you can see these patients had very good control overall, median of basically a year, although it didn't meet its median progression-free survival. And so, the combined best response rates, again, close to 60%. Now, in the symptomatic cohort or symptomatic cohort, that was different. So these patients with maybe larger lesions and had symptoms, they didn't fare as well. So there still may be a role for additional interventions. But in practice, this tells us that for some patients, we may be able to treat with these immunotherapies or combined therapies alone. You saw the presentation from Dr. Moyers with a COMBI-MB study, again, showing a good response rate, although unfortunately not as durable as we would like it. And we do have to be mindful of some potential combined toxicity of using these inhibitors at the same time as giving brain-directed radiation. So in our practice, when we're thinking about these patients that are coming in, if they're symptomatic or bulky and BRAF mutants, we often will consider giving combination therapy. If not, we think about more conventional therapies of radiation, and certainly if they're symptomatic, even consider surgery. But if they're not symptomatic, our mainstay approach is, especially for small lesions, to think about now combination immunotherapy because of the great responses. So just in the last minute, I would just talk about emerging multimodal therapy. So now we're thinking about how to combine these things. So using radiosurgery with the immunotherapy, there's some early data that's suggestive that there's a benefit to combining them concurrently at the same time, rather than just using them sequentially, again, shown by these waterfall plots with better responses in combination. There is some concern, again, that when we combine things, that we may also increase the toxicity of that. This has been somewhat variable among studies, but as a product of both radiation and immunotherapy, there may be some increased scarring or injury to regional brain tissue. Another technique in radiation is to use implanted radiation to deliver it from the inside out, sometimes in combination with surgery. Some studies have been done mostly in the retreatment setting when patients treated, and then we have to go back because it wasn't completely effective. But these are very small. They look like little iron filings of radioactive material that has a very limited half-life that we can now use and are studying in patients who are undergoing both surgeries for brain-directed therapy. And there's a long history of this use in various settings, but shows very good safety and efficacy. And finally, just talk about laser interstitial thermal therapy. This is a surgical technique that uses thermal ablation via a craniectomy-based probe. So you place a laser probe with MR guidance, and this is able to deliver essentially laser and heat therapy that has a number of really interesting biological effects, not just to coagulate or destroy tissue, but also potentially to augment the immune system in this region through induction of heat shock factors and then encouraging TILs and macrophages to enter. So it can potentiate both chemotherapy, ionizing radiation therapy, and the immune response. And I would just say that there have been some studies in this area for both the efficacy and also to treat some of that radiation injury. So in summary, we recognize that metastatic melanoma has a really high tropism in the brain and remains a problem. Outcomes have dramatically improved with CNS active immuno and targeted therapies. And has been a theme here, interdisciplinary therapy really allows for, I think, better optimization and personalization of response. And the questions that we're thinking about now are how do we sequence and combine these different therapies for an optimal response? So with that, I will thank you, and we can move on.